So our next speaker is Dr. Theodoridis. He has come to us from Dessau in Germany. He's part of a group with Professor Christos Zeboulis, who really, I think, has the distinction of being the most dedicated Degos researcher in the world, and hosted the meeting of Degos patients that occurred in Berlin 2 years ago. So thank you so much for coming all this way to be with us.
I would like to thank you for inviting me to speak here. I will present to you some important epidemiological data and some basic research aspects of Degos disease that was performed in our department. One more time, I will show you the typical clinical pictures of Degos disease with these typical porcelain white lesions with an erythematous rim, mainly scattered on the trunk and the extremities. And this is a typical histological picture of Degos disease with this wedge-shaped necrosis with overlying epidermal atrophy and hyperkeratosis. Unfortunately, the histological picture of Degos disease is relatively inconsistent, and we cannot say that we always find this typical picture. So we performed a statistical analysis of 202 patients. We had 168 patients from the literature that were described between 1941 and 2007. We compared the statistical analysis with another one that was done by Borg in 1989, and his statistical analysis included 101 patients. We didn't find any big differences considering the gender involvement, 60% to 40% males to females. In our study, in a sample with 170 patients, we find 54% males and 46% females. Borg did not provide any data about the family history of the patients that he examined. On the other hand, in a sample of 61 patients, we found out that 67% didn't have any familial disease, and 33% did have a positive family history. Considering the systemic involvement, we also found relative similar results with Borg. 37 to 63, no systemic involvement. Indeed, systemic involvement. We found out 42% of the patients didn't have any systemic complaints, while 58% in a sample of 178 patients did have a systemic involvement. This graph shows exactly the same percentages that I described you, that there are no statistical differences between my study or our study and the study of Borg. Family history is here being shown, and also no significant differences considering the systemic involvement. We performed also a separate statistical analysis considering the systemic involvement in both sexes. We found out that 40% of the males and 60% of the females did have a positive family history. However, this was not statistically significant. On the other hand, there was a statistical significance considering the systemic involvement. It means that the males are more frequently involved systemically than the females, 65% to 35%. This is data about the prognosis of patients considering the systemic involvements. We found out that especially by males, the prognosis is relatively grim in case of a systemic involvement, with 84.5% having a lethal outcome. On the other hand, the prognosis is a little bit better, but indeed also grim for the females, with a 65.6% having a lethal outcome in case of a systemic involvement. The mean survival time for both sexes in case of a systemic involvement was 2.4 years. This curve shows the the distribution of the patients in our study in the different age groups, and we found out that the curve makes a plateau between the 25th year and the 45th year of age, with a mean age of manifestation of 33.3 years. Comparing with the study of Burke, he found out a similar mean age of manifestation being 35 years. There was a slight difference considering also the age of manifestation between the males and the females. We see that the males, in case that they get the disease, they get it relatively younger. In case of a systemic involvement, we found out that 52% of the patients have a simultaneous involvement of multiple organs, while 30% of the patients with a single organ involvement had an involvement of the GI tract, 15% of the CNS, and 3% of other organs like the kidneys, the lungs, or the heart. The cause of lethal outcome in the patients that eventually died was mainly the involvement of the gastrointestinal tract with development of a lethal peritonitis. On the second place came the CNS involvement. 3% of the patients died because they had simultaneous multi-organ involvement, and 6% of the patients died because of an involvement of another organ. This curve that was performed in the statistical analysis shows that from the patients that eventually did have a systemic involvement, how many years did the systemic complaints appeared after the development of the first skin symptoms. And we found out that the average duration until the systemic manifestation was 2.4 years. And in addition to that, we found out that almost 90% of the patients that did eventually had systemic complaints did so within the first 5 years of disease. That means if we draw the conclusion that the first 4 to 5 years of disease are very crucial in order to find out if a patient is going to develop systemic complaints or not. Considering the research aspects of the disease, we know that there are 3 theories considering the pathogenesis of the disease. The first theory says that the disease is a vasculitis. The second theory says that it's a problem with the coagulation system. And the third theory says that the disease is related with a problem in the endothelial cells. What we decided to do, we picked out the 11 systemic vasculitides according to the Chapel-Hill classification, the giant cell arteritis, the Takayasu arteritis, the polyarteritis nodosa, Kawasaki's, Wegener's, the microscopic polyangiitis, the Church-Strauss syndrome, and the henoch-Schönlein purpura, as well as the cryoglobulinemic vasculitis, the leukocytoclastic vasculitis, and the anti-GBM disease. And we looked in the literature to find out which of the cytokines in these 11 vasculitides are more frequently increased. And the more frequently increased cytokines were interferon gamma, interleukin 1b, interleukin 6 and 8, as well as the tumor necrosis factor alpha, the VEGF, the MCP1, and the transforming growth factor beta. Some properties of these interleukins that we examined. Interleukin 6 is an important mediator of several infectious and autoimmune diseases. It's involved in diseases like HIV, rheumatoid arthritis, and autoimmune disease. In Castleman's disease, interleukin 8 is involved in the stimulation of the neutrophils and the T lymphocytes. It's involved in various autoimmune diseases like immune vasculitis, psoriasis, or inflammatory bowel disease. Interleukin-1 beta is involved in the polymorphonuclear cells activation, and it's involved in similar diseases like Crohn's disease or rheumatoid arthritis. Interferon gamma is a very well-known cytokine. It suppresses the Th2 reaction, and it modulates the differentiation of the B cells. It's related with the pathogenesis of lupus erythematosus, as well as diabetes mellitus and multiple sclerosis. The tumor necrosis factor alpha is an important cytokine involved in various inflammatory conditions like infectious or not, and the HIV. The vascular endothelial growth factor that we discussed so much today is involved in the angiogenesis, and it increases the vascular permeability. MCP1 attracts the monocytes, and finally transforming growth factor beta 1 is involved in the wound healing and is related with the diseases like the lupus, the thrombotic thrombocytopenic purpura, and neurodegeneration. We managed to collect samples from 6 patients the samples were collected during the first meeting of Degos patients that was performed in Berlin 2 years ago. In addition to that, we had 8 age and sex-matched controls. First, since the literature describes a frequently increase in the cardiolipin antibodies, we decided to examine the different groups of these antibodies, and we found out that indeed 4 out of 6 patients had increased IgG class anticardiolipin antibodies, and 3 out of 6 had an increase of the IgM class. The other classes of antiphospholipid antibodies like beta-2 glycoprotein, as well as phosphatidyl-choline, ethanolamine, and inositol, as well as phosphatidylserine antibodies and anti-sphingomyelin antibodies, were not increased in any patients. Then we examined the cytokines, and we found out that there were no differences between patients and controls considering interleukin-1 beta and interleukin-6. Interleukin-8 was slightly increased by the patients. However, it was within the normal range that was examined in literature considering healthy individuals. In addition to that, I have to say that by all patients and controls, we examined laboratory the value of C-reactive protein in order to exclude another systemic inflammatory condition that could eventually lead to an increase of the cytokines. In addition to that, we found slight differences considering MCP1, VEGF-A, interferon gamma, and TNF tumor necrosis factor alpha between patients and controls, but we have to say that these differences were not statistically significant. This was the same case with transforming growth factor beta 1. We didn't find any statistically significant difference between the patients and the controls. So, since all these factors that could point to an inflammatory condition were not increased in blood, comes one more time the reassurance that the Degos disease is not a vasculitis, but probably a vasculopathy. And in addition to that, we do not have constant histologic evidence that the disease is also a vasculitis. Secondly, the disease is not a lupus variant, since the already known typical features for lupus erythematosus are not present, like the light aggravation or the involvement of the face we have an exception of the foot soles, of course, and also lupus erythematosus is also characterized by a vasculitis. In addition to that, some people said that the Degos disease is a variant of the antiphospholipid syndrome. However, although we think that the antibodies may play a role in the disease, in the vast majority of the cases in literature, not all Degos patients have also increased antiphospholipid antibodies. We found out important epidemiological data also, like the mean age of manifestation, that the mean duration of disease in case of a lethal outcome, in case of a systemic involvement, is about 2.4 years. In addition to that, 90% of the patients that did develop systemic disease did so within the first 5.5 years of disease. There is unfortunately an almost 89% mortality in case of systemic involvement, and the males do have a worse prognosis because they are more frequently systematically involved, and in addition to that, they have an increased mortality rate in case of systemic disease. Thank you for your attention.